This is a lecture about Non-Entamoeba histolytica intestinal protozoans. If you still haven't watched it, watch my two-part Entamoeba histolytica lecture series. Link is in the description below. The focus of this lecture will be on Giardia, Balantidium, and some common intestinal commensals. Let's go! Here are our learning outcomes for this lecture. At the end of the lecture, the learner should be able to review general characteristics of intestinal protozoans, differentiate morphologic features of Giardia, Balantidium, and intestinal commensals, illustrate the life cycle of these parasites, discuss the pathogenesis and clinical features of these parasites, discuss general diagnostic and therapeutic strategies, and integrate important concepts with a specific clinical case. Most intestinal protozoans, and definitely the ones we will be talking about in this lecture, belong to these sections of the medical parasite taxonomic tree. You may have encountered the coccidians from another lecture series. These are your Cryptosporidium, your Cystoisospora, and Cyclospora. But if you haven't, please watch the lecture series. Again, link is in the description below. Another important point for review is that most protozoans exist in two forms: the dormant, highly resistant cyst stage, and the actively feeding and the usually motile but usually more vulnerable trophozoite stage. Please make sure to understand the distinction between these two protozoan life cycle stages. And lastly, for our review for this lecture, we need to understand the architecture of the human intestinal tract. I'd like to cite and quote Levin Lemoyle and Servin in 2006. The top image shows the organization of intestinal crypts and villus cells. Epithelial cells migrate up the crypt where they undergo differentiation, acquiring specific intestinal functions of absorption and secretion. Now, three cell types differentiate as they migrate: the predominant enterocytes, the mucus-secreting goblet cells, and the peptide hormone-secreting enteroendocrine cells. The bottom image shows the assembly of the polarized epithelial cell types. This organization provides a permeability barrier between the external intestinal lumen and the internal compartments. This barrier function is assumed by various junctions that we will not discuss in detail. The apical end of enterocytes express a dense, well-ordered brush border consisting of organized microvilli. Now, Paneth cells containing AMPs and antimicrobial proteins are also present. Enteric pathogens interact with the intestinal epithelial cells. They enter the cells, and these affect the cell architecture or organization and generally disturb the cell functions. The commensal organisms, the blue and green shapes over there, mainly reside in the lumen outside the mucous layer. Now, secreted mucins coating the epithelial surface in association with membrane-bound mucins act as a physicochemical barrier for the protection of the epithelial cell surface against undesirable pathogens. Let's now introduce our trigger case by Budesini et al. A 4-year-old boy went into the pediatric outpatient department in a South Central Asian hospital complaining of diarrhea since 2 years of age. Now, developmental milestones were unremarkable, but the child was underweight for his age, and there was observable ascites and bilateral pitting edema. The patient showed hypoalbuminemia, which probably explains the ascites and edema, but the cause of it was not clear at this point. I'll share the results of the endoscopy and biopsy at the end of the lecture. At this point, think about the potential non-parasitic causes for this clinical presentation. Let's now proceed with the lecture proper. Let's now discuss our first organism, Giardia lamblia. Giardia lamblia, or Giardia intestinalis, or Giardia duodenalis, is a common intestinal protozoan, especially in tropical and low-income countries, but can be seen worldwide. It is a known cause of epidemics and outbreaks of the disease called giardiasis. Giardia belongs to the older taxonomic classification Mastigophora since it is a flagellated protozoan. Now, the trophozoite possesses a characteristic four pairs of external flagella, and the ventral side contains an adhesive disc that it uses to attach to the intestinal mucosa. The trophozoite also possesses two distinct nuclei, which makes it look like an old man's face, or at least a face. The trophozoite is also teardrop or kite-like in shape compared to the oval cyst. Cysts contain up to four nuclei and prominent axonemes in its median. The images on the right are stained stool samples showing both a Giardia cyst and a trophozoite, as well as a scanning electron micrograph of both cysts and trophozoites. The C are the cysts, the T are the trophozoites. Giardiasis infections start when a person ingests food, water, or fecal material contaminated with mature Giardia cyst. In most cases, giardiasis is considered a waterborne parasitosis. The cysts travel down the gastrointestinal tract where stomach acids break down the cyst wall, and upon reaching the intestines, two trophozoites are released per cyst. Some trophozoites multiply by binary fission and attach on the epithelial lining of the duodenum or proximal jejunum, and some trophozoites transform back into cysts, especially when the stool reaches the colon. Both cysts and trophozoites can be seen in human fecal matter, but trophozoites usually do not survive in the outside environment. However, cysts can contaminate other food or water sources, completing the life cycle. Giardiasis starts when the trophozoites begin attaching to the apical end of the enterocytes using their ventral sucking disc. They attach using mechanical forces and interactions with lectins and annexins as reported by Martinez-Gordillo et al. This attachment leads to shortening and destruction of the microvilli of the enterocyte brush border, activation of CD8 T lymphocytes, rupturing tight junctions, and thereby altering the permeability of the intestinal lining, causing enterocyte apoptosis. The adaptive response then kicks in with dendritic cells, mast cells, and CD4 T cells producing interleukin 6, IL-17, TNF alpha, and even secretory immunoglobulin A. Nitric oxide is also produced, which inhibits trophozoite proliferation and promotes intestinal peristalsis, which eventually leads to the expulsion of the trophozoites. Giardia has evolved to colonize the hostile environment primarily by several mechanisms. Cysteine proteases are recently considered as a major virulence factor for Giardia, responsible for disruption of the tight junctions, the enterocyte cell deaths, mucus depletion, and degradation of host immune factors. Giardia also competes for arginine to reduce nitric oxide production by the enterocytes. The parasite also facilitates antigenic variation by expressing different variant surface proteins or VSPs, enabling some variants to escape the human immune response. Despite these virulence factors, Giardia is generally considered to be non-invasive, which means they usually stay within the intestinal lumen and do not invade past the mucosal layer. The presentation of giardiasis varies according to Giardia type, the host immune response, and other variables. Generally speaking, about half of infected patients clear the infection without producing significant symptoms. About 15% become carriers, continually shedding infective cysts in their stools without causing discernible symptoms for more than 6 months. This is especially concerning with food handlers who do not get tested, as they can cause outbreaks without anyone's knowledge. The remaining 35% of cases become symptomatic. Symptoms usually develop after about a few weeks from ingestion of contaminated food or water. Most acute cases manifest with diarrhea, either watery or steatorrheic, meaning fatty or foul-smelling stools. And other common symptoms include general body malaise, excessive flatulence, abdominal cramps, bloating, nausea, weight loss, and the weight loss is most likely due to water loss. Most acute cases can be self-limiting with an average duration of about 2 weeks. But those who do not clear the symptomatic infection may develop chronic giardiasis, where you can see malabsorption symptoms, profound weight loss, and even stunted growth and malnutrition, especially in younger patients. In about 40% of cases, patients may actually develop acquired lactose intolerance. Definitive diagnosis of Giardia infections are primarily done by microscopic visualization of either cysts or trophozoites from fresh stool samples, usually using direct fecal smears. You should be able to see the characteristic falling leaf motility exhibited by live Giardia trophozoites. Stool concentration techniques, duodenal and jejunal aspirations, or an enterotest can be used for higher diagnostic sensitivity. Newer diagnostic tools include direct immunofluorescent assays, ELISA, and polymerase chain reactions, and these methods provide higher sensitivity and faster turnaround time compared with microscopy. Giardiasis is treated using nitro group containing compounds. These include the nitroimidazole metronidazole, as well as the nitrothiazolide nitazoxanide, and in resistant cases of giardiasis, albendazole may also be used as a second-line drug. These drugs achieve a high cure rate and should be administered even to asymptomatic carriers to stop their shedding of Giardia cysts. One natural strategy against Giardia trophozoites in chronic giardiasis is to starve them of proteins, specifically the amino acid arginine, using a low-protein diet, but this approach needs more validation. Our second parasite in this lecture is Balantidium coli or B. coli. Balantidium coli is the only ciliated protozoa known to infect humans. Balantidium is a large protozoan measuring up to 200 micrometers compared to about 20 micrometers for Giardia. Therefore, while most intestinal protozoans are barely visible using high power magnification, with a trained eye, Balantidium can be seen even while using low power magnification. The trophozoite has a lot of unique structures like the presence of numerous cilia surrounding its entire cell membrane. There is also this prominent kidney-shaped macronucleus, as well as multiple large cytoplasmic vacuoles. The trophozoite also presents with a cytostome, which it uses to ingest its food. The cyst is circular in shape and often the infective stage since, again, trophozoites cannot withstand the external environment. The main reservoir host for Balantidium are pigs. Therefore, a lot of cases are seen among pig farmers or those who handle raw pork products. Aside from pigs, other possible reservoir hosts are rodents and non-human primates. Infection starts when humans or the other reservoir hosts ingest food or water contaminated with Balantidium cysts, and following ingestion, excistation occurs in the small intestine. The trophozoites then move into and colonize the lumen of the large intestine and also the appendix of humans and animals, where they replicate by binary fission. Some trophozoites undergo encystation to produce infective cysts, which are passed out in stool. In most cases, Balantidium coli trophozoites just reside in the lumen of the colon and ingest nutrients using its cytostome. A lot of cases remain asymptomatic. However, it can also cause the disease called balantidiasis. Balantidiasis usually manifests with watery diarrhea or even dysentery, similar to amoebiasis. Other symptoms include weight loss and abdominal pain. However, Balantidium can become invasive and cause serious disease. In a conference paper by Adame et al. In 2019 in Guadalajara, Mexico, they presented the histopathologic photos you see here. These are photos of pig intestines presenting with ulcers with Balantidium trophozoites invading the mucosa. Parasite invasion is mainly due to the secretion of hyaluronidase, which degrades the hyaluronic acid of the intestinal mucosa, which is important in maintaining its ultrastructure. These ulcers can cause other complications such as fulminant colitis or even extraintestinal disease, especially in patients with immune problems. Balantidium can be diagnosed using microscopy of direct fecal smears. Take note of the rolling motion of the trophozoites as it moves around using its cilia while it sucks nutrients from its surroundings. Biopsy samples from colonoscopy or sigmoidoscopy can also provide additional diagnosis. The drug of choice of balantidiasis is tetracycline. Second-line drugs include metronidazole and tinidazole. Before we proceed to the intestinal commensal protozoans, let's do a quick fire round about 3 other possibly pathogenic intestinal protozoans. Sarcocystis was previously thought of as a fungi, but is now considered an intestinal protozoan which closely resembles Toxoplasma rather than the other intestinal protozoans. Humans are the definitive hosts, but other species infect other animals as well. Definitive hosts get infected by ingesting infected meat from intermediate hosts such as cows and pigs. Most cases of sarcocystis resolve spontaneously, so treatment is rarely required. But if they cause disease, symptoms include non-specific complaints such as diarrhea, mild fever, and vomiting. In some cases, sarcocystis can become invasive. Invasive sarcocystis form structures called sarcocysts, which usually reside inside muscle tissues. Blastocystis hominis was previously classified as a yeast, but is now considered a protozoan. The life cycle of this parasite remains unclear, but it is postulated that it follows a simple, circular, fecal-oral cycle with the cyst form as its infective stage. It is still unclear if blastocystis actually cause human pathology, but symptoms associated with numerous cysts include bloating, abdominal pain, flatulence, and mild diarrhea. In such cases, metronidazole is given as empiric treatment. Dientamoeba fragilis was incorrectly classified as an amoeba, but later molecularly reclassified as an amoeboflagellate, closely related to Trichomonas and possessing both pseudopodia and flagella. However, the flagella is very difficult to see, even in trophozoites. Another important distinction of this parasite is that its transmission is associated with enterobius or pinworm infections. Symptoms associated with this parasite include intermittent diarrhea, colicky abdominal pain, again bloating and flatulence, and irritable bowel syndrome. Treatment is through iodoquinol, metronidazole, or tetracycline. Now we are down to our last topic. We will now discuss non-pathogenic intestinal protozoans or the intestinal protozoan commensals. Non-pathogenic intestinal protozoans include Endolimax nana, Iodamoeba buishli, and the non-histolytica entamoebas. You have your Entamoebas puleki, hartmanni, and coli. These are all acquired through ingestion of food or water sources contaminated with the cysts of these parasites. They inhabit the large intestines, but since they are non-pathogenic, they do not cause human disease. Humans pass out cysts or trophozoites of these protozoans in their stools. So why do we need to study these organisms then? Because these organisms act as sentinel organisms that warn you of possible fecal contamination of your food or water sources. Now, if these organisms are seen in a stool sample, then the food or water source may be at high risk for pathogenic parasites that are also transmitted via the fecal oral route. Parasites such as Giardia, Balantidium, Cryptosporidium, Toxoplasma, and even helminths or worms such as Ascaris or Trichuris. Here's a summary table of the 5 non-pathogenic intestinal protozoans. Take note of the similarities and differences between each protozoan, as well as the similarities and differences between the cysts and trophozoites of each one. Entamoeba coli are larger, with cysts containing numerous nuclei. Karyosomes are also eccentrically located within the nucleus. Entamoeba hartmanni looks very similar to the pathologic Entamoeba histolytica, but about half the size. It has a single nucleus and a centrally located karyosome. Entamoeba poleki has a single large nucleus with a relatively large pleomorphic karyosome inside. You can also see multiple chromatoid bodies inside the cysts. Cysts of Endolimax nana have exactly 4 small nuclei, while trophozoites have a single large nucleus with a large blot-like karyosome. Iodamoeba bushleash cysts have a single nucleus with a distinct large glycogen vacuole. Trophozoites of Iodamoeba are morphologically similar to those of Endolimax nana. Now let's go back to our trigger case. As a recap, we have a 4-year-old patient with wasting and chronic diarrhea for 2 years, with signs and symptoms of fluid retention. There is evidence of possible Entamoeba histolytica infection, but is there another culprit? Endoscopy and biopsy showed blunting of the intestinal villi with numerous trophozoites of Giardia lamblia along the surface epithelium. So that's the diagnosis. As we've learned earlier, Giardia infection causes blunting and destruction of intestinal villi, causing malabsorption symptoms. Giardia also directly competes with amino acid absorption, particularly arginine. Having had diarrhea for 2 years, our young patient shows consistent signs and symptoms of chronic protein malnutrition. He has low weight, he has hypoalbuminemia, and this presents with ascites and edema. The patient was treated with metronidazole and his hypoalbuminemia was treated with albumin transfusion, and the patient eventually recovered. To wrap up the lecture, let me share a 2022 study in the Philippines by Palar et al., where they studied vegetable farms in selected communities and found more than 17% of vegetables, particularly lettuce, whether iceberg or romaine lettuce, and more than 47% of soil samples, and more than 73% of water samples were actually contaminated with one or more parasites. These include Giardia and Balantidium, 2 of the pathogenic protozoans we just discussed in this lecture. Now, their study suggests that fecal contamination of soil, food, and water is still prevalent, especially in rural communities. I hope you found this lecture informative. Check out my other lectures. Peace.